Good afternoon, everyone. We're very pleased to see such a broad audience during this afternoon session. You're still with us and still awake. Thank you very much. My name is Katarzyna Kotwis. I come from Szczecin, Poland, and I will be co-chairing with this session with
Pedro Pova from Lisbon, Portugal.
And we'd like to carry on and invite the first speaker, who is Luigi Camporota from Guy's and St. Thomas's NHS Foundation Trust in London, UK.
Thank you so much, and good evening, everyone. It's always a pleasure to be here with you and sharing a few thoughts about prone positioning, but mainly what we've learned about COVID-19. So I've got no conflict of interest for this talk, and I just want to start with the idea about prone positioning. As you all know, the pathophysiological idea of prone positioning is based on this anatomical model of ARDS, which is the sponge model of the lung. Essentially, you've got increasing pleural pressure from the ventral to the dorsal. You've got gravity with superimposed weight, and then air gets squeezed out, and then essentially we've got a consolidation, and that could be reversed through prone positioning, regaining aeration in the dorsal position. But you are very well aware that during COVID-19, the situation, particularly at the beginning of the first wave, was very different. You can see a very different pattern of consolidation or collapse, but the main thing was a perfusion defect. You know, there were areas of hyperperfused area of the lung where there was some ground glass or some consolidation. And that led to this idea, which is very interesting. You can see this is a, let's call it typical ARDS, and this is COVID-19 ARDS. And you can see that in COVID-19 ARDS, there were more dilated vessels in the area of consolidated lung, which led to greater dead space and shunt fraction for the same anatomical consolidation, which also was related to mortality. So the greater the dilated vessel score, the greater the mortality. Also, there was another confounding factor which was demonstrated subsequently, that there was an opening of the intrapulmonary bronchopulmonary anastomosis, essentially creating an extracardiac and extrapulmonary shunt, which obviously is not affected by recruitment or sometimes by prone positioning. So that was the position that we were when we are not sure during COVID-19 whether the pattern that we saw in typical ARDS was replicatable in the COVID-19 ARDS. And this is just the idea, it's a modeling, but it's very interesting because when you compare patients with an anatomical shunt based on CT scan calculated about 17%, when the shunt fraction was calculated based on gas exchange, that was more similar to 50%. So there was a threefold increase in shunt fraction, which was due to a pulmonary vascular abnormality. So let's see what happens in a prone position during COVID-19. Let's start with the physiology. And this is a very common, you're very familiar with this, essentially in supine position, follow the feet. You can see there is a mismatch between ventilation and perfusion. And so there is a change in ventilation-perfusion matching, which goes high in the sternum, so more perfusion, more ventilation than perfusion, and then it lowers down into the vertebrae, so from dead space to shunt fraction. And obviously, prone position has the effect in traditional ARDS of making it flatter, so more homogeneous. And this has been replicated also in COVID-19. This is work from Sandro Rossi, and you can see these are patients in supine position of 5 centimeters of water of PEEP, and these are 35 centimeters of water of PEEP. You can see the great heterogeneity of ventilation gas tissue ratio, so much more in the sternal, much less in the vertebral. And you can see the effect of prone position in COVID-19 has been that of making it much more homogeneous, so very similar to normal ARDS. Now, this is a It's a study comparing CT scan and EIT. You can see in blue the EIT is a ventilation map, and in red here is the perfusion map. So what you can see is two things. First, you can see recruitment in prone position, particularly of the dorsal regions, and a reduction, so a atelectasis in the ventral region. So we gain some, we lose some, but on balance, we increase recruitment. But what is more important, if you see these two maps, the blue and the red map, you can see there is a discrepancy in supine position. So there is more ventilation than perfusion, so in other words, dead space, and that has been normalized in prone position. Again, this is in COVID-19. The other things we can see is, again, there is more aeration, so gaining of extra sort of end expiratory lung volume over time in prone position, which has the interesting and important effect of reducing strain over time. So that's quite important. And clearly this has affected gas exchange. You can see here, for example, as the reduction, there is a reduction in non-aerated lung tissue, there is clearly an increase in PF ratio. So this is the same in COVID-19 as it was in a more typical ARDS, let's say. So you can see here a delta non-aerated tissue, so a reduction, and there is a reduction also in venous admixture. What about the outcomes? The outcomes will tell us this is a study where we compared normal ARDS, or typical ARDS, response between supine and prone, and COVID-19 between supine and prone. And you can see the pattern of response overall is very similar. So about 80% responders rate, commonly the same for typical ARDS and COVID ARDS. But what was important is that responders had a greater chance of surviving. And this has been replicated in other studies. And you can see here, I've simplified the study, but basically you can see there is no difference, at least statistically speaking, in the relative risk of death between ARDS and CARDS. But again, responders, strong signal towards improved outcome. And you can see the average treatment effect, about 52 millimeter of mercury per session of prone positioning. And what is also interesting here, you can see the PF ratio change between supine and prone, and then the greater the PF ratio increase, the shorter the duration of mechanical ventilation. So that's quite encouraging. What about timing? What we found from our study was that patients who were proned early, and by early I mean within the first 24 hours, did much better compared to the ones that were proned late. And this has a biological rationale. You can see this is a study from Sandra Rossi and Luciano Gattinoni's group. This is CT scans of patients taken first week, second week, and third week. And what you can see here, that during the first week, there is more atelectatic tissue. Atelectasis means essentially there's loss of gas, and when you change the pleural pressure, you might regain aeration. And you can see that this amount of atelectasis remains quite stable in the first 3 weeks. But the consolidation, so when the lung volume is preserved but is full of other things, so there is no air, but there is also difficulty in regaining aeration, that increases over time. And that has been associated with the recruitability or the improvement in aeration following prone positioning. But this is not universal finding. And in fact, in this study, for example, you can see that there is no much difference between early proning and non-early prone positioning. But then again, there are limitations in these studies because we don't know exactly when they met the criteria for proning. So it's possible that the first met the criteria for proning later on in their stay, rather than being a really late proner as a deficit prerequisite in applying evidence-based medicine. And this is the same concept that comes from a different study from Northern Europe. What about duration? And duration is quite interesting because you can see here, and we all know during COVID-19, particularly the great load of patients. I mean, in my hospital, we had 61 patients to be prone each day. And you can see that some patients might have skipped 1 or 2 supine prone series, and some patients were prone for much longer. So you can say, what is the advantage of leaving these patients in prone position for longer? Let's say more than 24 hours. What about 48 hours? And this is some studies you can see here. The numbers are not huge, but impressive enough. 110 patients, you can see prolonged prone position, average 40 hours versus the normal average recommended about 17 hours. And yet there is a beneficial effect in terms of survival for patients who were received more prolonged proning. This is as a whole, but much more of an effect in patients with PF ratio less than 150 or 20 kilopascal, depending on how you prefer. The important thing is that there was a significant reduction in workload, as we might expect, but there was also very minor injuries, so there was well tolerated and quite safe. And you can see here that the gas exchange continued to improve beyond the first 16 hours. The other thing that we've done during COVID-19, and I think has changed what we've practiced over time, was awake prone positioning. And there were physiological effects of awake prone positioning. So you can see this is a study from Davide Chiumello. You can see not only did the PF ratio improve, but also the work of breathing. So the respiratory effort improved going from supine to prone position, which is very important as a patient relevant outcome. And this is a meta-analysis which I've redrawn just to simplify. You can see that there is no mortality benefit. However, there is a reduction in intubation, and that is seen particularly in patients who received advanced respiratory support and within the ICU. And when you look at this busy slide, but essentially I've highlighted the main point to say when you put all the studies together and you look at intubation as an outcome or mortality as an outcome, you can see there is no difference in mortality, but there is a quite good signal in favor of prevention of intubation. And you can see there, particularly if the PF ratio is below the 150 threshold. And this is my final slide before the conclusion, to say that there seems to be a dose effect or a duration effect. You can see here, for example, the risk of intubation and the risk of hospital mortality, which seems to be improving or increasing in terms of effect size with a longer duration. So you've got very little before 6 hours, and improves the size effect the more prolonged we can apply this intervention. And this brings me to, my conclusion. I hope I'm on time. Just to say that 4 points really. One, that responders to prone position have improved survival, and this is similar between COVID-19 ARDS and the typical ARDS. We've seen the response to prone position seems to depend and make sense physiologically on the dose, i.e. the duration of prone positioning. But then we need to be careful when we interpret changes in gases, so oxygenation importantly, but also carbon dioxide. We need to think about the vascular abnormalities that we see in COVID-19. So they might reflect both recruitment, but also might reflect the redistribution of blood flow. So we need to be mindful of the variation in the pathophysiology of the two conditions. And then clearly awake proning for at least 6 hours, if not more, are associated with a reduction in the risk of intubation. And with that, with 21 seconds to spare, I would like to thank you for your attention.
Interesting presentation, very broad. Are there any questions from the audience? Would like to encourage you to ask questions.
Hi, thank you for the beautiful presentation. Alessandro Santini from Milan. Regarding the response to prone positioning and benefit in mortality, in classical ARDS, let's say, there's not a, like the benefit of prone positioning is independent of the PF ratio improvement, meaning you don't need to improve in PF ratio to go on proning the patient. Is it like COVID is different, or do you think there's something else happening here? Like, for example, physicians seeing an improvement in PF ratio during prone position are more prone, let's say, the day after to prone again the patient, and instead, so is it a problem of how many prone positioning sessions the patient makes, or what do you think it is? Thank you.
I think it's a great question. Thank you for that. So first of all, what you're saying is that in a way, if we don't see a change in PF ratio, that shouldn't discourage us from continuing prone position, which I completely agree with you. At the same time, there is a human behavior, which is what you said. If you don't see a benefit for something which might increase the risk for the patient and the increase in workload, it might discouraging you for using it. Absolutely, I agree. The thing is, most of the studies, the limitation that we examined, and most studies examine only the effect after the first prone positioning. So I think it would be very interesting to study repeat prone positioning. Obviously, there was an original study from Professor Gattinoni's in the New England Journal, where in the supplement, he showed the difference day by day between supine and prone, but we don't have that data for COVID-19, at least not in the study that I presented, but it's a very good question.
Thank you.
Okay, thank you very much,
Thank you.
Luigi. So let's move for the next speaker. That is Professor Jean-Louis Teboul. That is from Hôpital de Bicêtre, Paris South University, Le Kremlin-Bicêtre in France. That will address the issue of hemodynamics in prone position.
Thank you very much, Pedro. So good afternoon, everyone. I will talk about a little bit hemodynamics during prone position, my conflict of interest. Probably you are convinced that prone position is a common treatment in ARDS patients, especially in COVID-19 patients. In this study, a global unit study published some months ago, around 65-67% of COVID-19 patients were prone during their stay in the ICU. I will talk about some elements we are in this paper, which was published 2 days ago in Critical Care with Christopher Lai and Xavier Monet. And if you want to know more about my talk, you can look at this paper, so you can now finally leave the room. But I will try, nevertheless, to convince you that there are some hemodynamic effects. So I start from this prone position. And 3 events can occur during prone positioning, which can affect hemodynamics. First, increase in intra-abdominal pressure, increase in arterial oxygenation, and increased lung recruitment. Increase in intra-abdominal pressure, there are many papers showing that. This is one of them coming from our group with Christopher Lai. In patients who increase or not cardiac index, prone position increased intra-abdominal pressure, sometimes a lot, sometimes not, it depends. Arterial oxygenation, of course, this is one of the objectives of prone positioning, is to improve arterial oxygenation. And lung recruitment, this is another objective of prone positioning, is to recruit lungs. And we know that not all patients have recruited lungs, and In this paper by Martincourt and others, they show that in COVID-19 patients, there is a good correlation between the increase in compliance of the respiratory system from supine to prone and the air to eye ratio. Okay, these three events can have some hemodynamic consequences. Let's start by lung recruitment. You know that in the lungs, you have two categories of microvessels. You have extra-alveolar microvessels and intra-alveolar microvessels. When you increase lung, you have a compression of the intra-alveolar vessels, but a dilation of the extra-alveolar vessels. If I represent this on this graph, it is a classical graph with pulmonary vascular resistance on the y-axis, the lung volume on the x-axis from residual volume to total lung capacity, the resistance of the extra-alveolar vessels decreased from RV to TLC. But we also have intra-alveolar vessels, and the resistance of these vessels increased with lung volume. And the resultant effect is this kind of U-shaped curve, very classical curve, and the nadir of this curve, the minimal value of the resistance, are at the level of the RFRC. Knowing that, if you recruit lungs with prone position, for example, starting from a value of end expiratory lung volume which is below RFRC, you can improve and you can decrease the pulmonary vascular resistance. So lung recruitment is supposed to increase or to decrease pulmonary vascular resistance. And this is associated with a decrease in PVR due to the improvement of PaO2 by the decrease in hypoxic vasoconstriction. So you have two effects resulting in a beneficial effect on pulmonary vascular resistance. And with Mathieu Zosviak, Xavier Monet, and others, we addressed the hemodynamic effects of prone positioning by using a Swangans catheter, and we observed that the gradient between the mean PAP and PAP decreased with prone position, and the pulmonary vascular resistance also decreased by 39%. It's not negligible. So now, at the opposite side, the venous side, we have, with prone position, an increase in the mean systemic pressure, which is due to the increase in abdominal pressure. In this study with Christopher Lai, we observe an increase in the mean systemic pressure, whatever the increase in cardiac output, in patients who increase or not cardiac output. Sometimes a huge increase in the systemic filling pressure, the mean systemic filling pressure. And normally, this results in an increase in the venous return pressure gradient, the difference between the mean systemic pressure and the CVP. And this is what we confirmed in this study. This gradient, this difference, increased with prone position in all the patients. But at the same time, as you know, the increase in abdominal pressure will increase the resistance to venous return. So there is a balance between both. And the resistance to venous return can increase a lot in patients who increase cardiac index as well as in patients who do not increase cardiac index with prone position. So if the increase in the venous return pressure gradient is higher than the increase in the resistance to venous return, this should result in increase in RV preload, in increase in central blood volume, and we know that increase in central blood volume also can decrease the pulmonary vascular resistance. Because when you increase central blood volume, you will increase the pulmonary venous pressure, and therefore you can decrease the extent of zone 2 conditions in the lungs, and you should decrease PVR, pulmonary vascular resistance. So again, you increase the extent of zone 3 by reducing the extent of zone 2, and you improve the pulmonary vascular resistance. And this should result in a decrease in the right ventricular afterload. And this decrease in RV afterload should result in a decrease in the RV-LV interdependence phenomenon. So in patients with dilated RV, this could be beneficial, and this could improve the LV preload by reducing the size of the right ventricle. In this paper I talked about already, we also used echocardiography, and we looked at the RV endoscopic area over LV endoscopic area ratio, which is a good marker of RV function, which decreased with prone position. And the LV eccentricity index, which is a marker of the septal shift, also improved with prone position. This should increase LV preload. At the same time, the improvement in RV preload should result in increase in RV output, and also the reduction in RV afterload, and this also should increase LV preload. So now it depends on the presence of preload responsiveness, preload reserve or not. If the left ventricle has some preload reserve, is preload responsive, you can improve cardiac output. If not, there is no change in cardiac output. Having said that, now we have to consider how to assess preload responsiveness. In this study with Mathieu Josviak, we looked at patients who increased cardiac index during prone position compared to supine, and patients who did not. And before proning the patient, we perform a passive leg raising before. And we observed that an increase in cardiac output by more than 8% during PLR can predict an increase in cardiac output by more than 15% during prone position compared to supine position. So this is a way to detect preload responsiveness, but before proning the patient. So now, I told you that sometimes, or not sometimes, you could have an increase in the resistance to venous return higher than the increase in the venous return pressure gradient. In this case, you should have a decrease in venous return. So cardiac output will decrease. So we have different situations, variable effects of prone position on hemodynamics. And in this paper with Christopher Lai, we looked at all these behaviors. And of course, increasing abdominal pressure, mean systemic pressure, CVP, or resistance to venous return. And of course, if you want to have an increase in cardiac output, you should be preload responsive. This is necessary. But sometimes cardiac output does not change or decrease, exceptionally decrease, but this is a possibility. This, of course, will happen in preload unresponsive patients, but this could happen in preload responsive patients when the venous return, the resistance to venous return are high due to the increase in abdominal pressure. This is what we observed here, a huge increase in the resistance to venous return, in particular in that patient who decreased cardiac output. Look at the huge increase, more than 200% of the resistance to venous return. And this happens when intra-abdominal pressure increases a lot. So what is important is that there is no increase in cardiac output in case of preload unresponsiveness. This is physiology. And an increase in cardiac output in case of preload responsiveness if the increase in intra-abdominal pressure is not excessive. So it is important to monitor intra-abdominal pressure when you prone the patient. It is also important to assess preload responsiveness before prone position or better during prone position. It could be better. And in a recent paper with Ruichi and others in my unit, we tried to look at the reliability of the tidal volume challenge during prone position. You know the tidal volume challenge consists in increasing tidal volume in patients who are ventilated with a low tidal volume, 6 ml per kilogram. You increase by 2 ml from 6 to 8, and you look at the change in pulse pressure variation. If pulse pressure variation increases a lot, more than 3.5% in the studies we did, probably the patient is fluid responsive. But this was demonstrated for patients in supine position. And this paper addressed the question in patients during prone position. And we found that this tidal volume change works well also in these patients with an area under the ROC curve of 0.94, which is better than PPV alone. But note that PPV is not bad in this study. ARDS patients with COVID-19, not all patients had COVID-19. We included patients with COVID-19, patients with no COVID-19. Nevertheless, PPV in this study was good during prone position. The area under the ROC curve was 0.85, but it was better to have a tidal volume challenge to improve the results. So I encourage you to do this during prone position. So the take-home messages of my presentation is that in patients with ARDS under protective ventilation, prone positioning decreases RV afterload, which is beneficial in cases of RV dysfunction. And cardiac output may increase in case of fluid responsiveness if the prone position-induced increase in intra-abdominal pressure is not excessive. So again, you can look at this recent paper to know more about the effects of prone position on hemodynamics. Thank you very much.
Thank you, Jean-Louis, for this excellent presentation. Any question, comment? I have one question for you. I think all of those patients were on invasive mechanical ventilation and probably on neuromuscular blockade. What are the differences during awake proning? I don't know. I cannot answer this question because we did not include patients in awake patients, and we prone awake patients, as probably everyone here, with COVID-19 and ARDS or beginning of ARDS, but we did not include this kind of patients, sorry. Yes, Marcelo.
Go ahead.
Hello, Jean-Louis, congratulations. This was excellent. When you are in supine, you have elevation of the head, and then in prone, I don't know about your hospital, but the patient gets completely horizontal. So this already...
So first, we put the patient not really horizontal, but 11, 12 degrees in the...
Inverse Trendelenburg.
Yeah, Trendelenburg. Nevertheless, not in this study, but in other studies, we looked at the effects of... the first effect of to prone, or to say, first, you start from the semi-recumbent position, then to the supine position, and then you prone the patient. And already we have some effects, hemodynamic effects, only when you start from the semi-recumbent position to the horizontal position, and then you prone the patient. Yes, we differentiated in this paper, Christopher, these two effects. Yes, I did not want to go into details, of course, not to make my presentation too complex.
Thank you very much.
Thank you.
We would like to welcome Daniel Talmor from Beth Israel Deaconess Medical Center to give a presentation on optimizing PEEP.
Okay, thank you very much. Thank you for inviting me. My talk is optimizing PEEP in the prone position. I have to say this is a relatively data-free zone, so I will do my best. Here are my disclosures. And I'm sure in the previous talks here, people have discussed the benefits of prone positioning. It's been used for decades in patients with ARDS. Physiologic benefits are relatively well described, so improved ventilation perfusion matching, recruitment of dependent lung regions, optimized chest wall and lung mechanics, enhanced draining of secretions. Use is common, and of course it became much more common during COVID-19. The appropriate ventilator settings, however, have really not been studied systematically. This is the key paper in the literature on prone positioning, came out in 2013. Somewhat surprising result, actually, because there had been a long history of negative studies in prone positioning before that. And if you look here, this is the order of publication of prone positioning papers. You can see starting in 2001 with Gattinoni's paper. And this is the cumulative odds ratio for benefit in prone positioning. So adding each study together, you can see how slowly the evidence built towards a positive message and a positive result for prone positioning overall. So this is a great study in science of how we incrementally learned and studies developed, each one on top of the previous study. So what were the changes that occurred over time? There were several key changes in the studies that were implemented and that probably account for the survival benefit. So we learned to have a higher proning dose. We kept patients in the prone position for longer. We enrolled patients early, the royal we, I didn't actually enroll anybody, but we enrolled patients earlier in the studies. We honed in on the patients most likely to benefit, so the P-to-F ratio of less than 150. There was obviously experience gained in the procedure. We all learned to prone really quickly during COVID-19, but it's not a benign procedure. We have to learn how to do it. But the studies didn't address the ventilator settings. And what happened was each study used the common ventilator strategy at the time the study was designed. So how did that look? You can see pretty clear cutoff here. The first studies all used high tidal volume. And that may well have been the reason that these studies were negative. So we continued high tidal volume from the supine position into the prone position. It's only when they began to use lower tidal volumes in the prone studies did we begin to see the effects. Now, it was low tidal volume in both arms, so it's not that the low tidal volume was the reason that the study was positive. It's just that implementing low tidal volume seems to have somehow improved the benefit of prone positioning. Now, do PEEP settings matter? So tidal volume settings do. We need to use low tidal volume during prone positioning. What can we learn from the studies? So here you see a series of the recent studies in prone positioning. You can see the PEEP level delivered in that study, and you can compare that to the PEEP levels that you would have gotten in one of the high PEEP trials. Okay, so all through these prone positioning studies, they used essentially moderate levels of PEEP. So this was the PEEP at baseline. This was the PEEP post-proning, and it was essentially between 8 and 10 in all studies. So very moderate levels of PEEP applied in the positive prone studies. And the question is that appropriate, or is there additional benefit that can be had by changing our PEEP strategy during proning? And here the literature gets sparse. So let's start to look at what happens to the chest and to the lungs when we prone a patient. And what are we actually looking at PEEP to do? So here you can see a sketch of what an ideal PEEP level would look like. So it's one that balances the risk of atelectasis trauma, so it expands the lung. At the same time, it prevents the injury from overdistension. And we think, the goal of every PEEP trial is to find where this sweet spot is, right? We can say it another way, and this is slightly more controversial, but I think most people would agree, that sweet spot is around a transpulmonary pressure of 0. So it's at the point where the chest wall, the pressure of the chest wall downwards is overcome by the pressure in the airway, inflating the lung, keeping the lung opened at end expiration. That's slightly controversial, but not that controversial. So we need to think about what happens to the transpulmonary pressure during prone positioning. So here's a study we did. This is in healthy patients in the operating room. They were getting spine surgery. And we placed esophageal balloons, and we looked at their expiratory reserve volume. And you can see what happened to the esophageal pressure during proning was essentially a decrease of about 5 centimeters of water in every patient. Okay, so if the pressure in the esophagus, so the surrogate for the pleural pressure, goes down, that means that the transpulmonary pressure goes up, because transpulmonary pressure is airway pressure minus esophageal pressure. So minus, that's a plus, and you get an increase in transpulmonary pressure. In other words, when we prone a patient, functionally we're increasing the PEEP by 5, because that's what the esophageal pressure changes. Now, you may say, does the position of the esophagus change when we prone the patient? So surprisingly, and unlike what we may remember from the anatomy lab, the esophagus is essentially a mid-thorax organ. It's not in the posterior portion, and the positional change as we prone the patient isn't that large. Now that increase in PEEP will measurably increase the volume of the lung. And you can see that here. So this is the expiratory reserve volume of the lung of these patients, and it went up pretty predictably. So already we know that by simply proning the patient, we're functionally increasing the PEEP. What else happens to the chest? So multiple studies have shown that the chest wall elastance increases in prone positioning. And elastance, the inverse of compliance, so what that means is the chest wall gets less compliant when we prone a patient. And probably that has to do simply with positioning. The anterior portion of the chest, which is more flexible, is pushed down on the bed by the weight of the patient, reducing the compliance of the chest wall. So if the compliance goes down, the elastance goes up, what does that do to the distribution of air in the lung? And this study, this is really a key study by Katira, Laurent Bouchard, and the late Brian Cavanaugh, showing what happens when we prone patients. So several key findings here. One is the gradient of the pleural pressure becomes much more homogeneous. So this is the gradient of the pleural pressure across the lung during the supine position. This is during prone positioning. So the distribution of air in the lung becomes more homogeneous due to those changes in chest wall compliance. And you can see the same during tidal ventilation. So this is dependent and this is the non-dependent and the dependent areas of the lung in the supine position, okay? And you can see there's a real difference in the distribution of ventilation at any level of PEEP during supine positioning. That seems to disappear in the prone positioning. Okay, that means that essentially any level of PEEP will give you the same effect in the distribution of ventilation in the lung, possibly meaning that the effect of PEEP during prone positioning is less. And you can see here the tidal recruitment improves during prone positioning in the dependent areas of the lung. So this is supine. You can see this is the dependent areas of the lung. This is the non-dependent. When we flip the patient, the non-dependent areas are aerated much better than they were during the supine positioning. On the other hand, this new distribution of air in the lung leads to less hyperinflation during prone positioning. So PEEP appears to be more benign during prone positioning. We can image this. So here are EIT images that show bedside assessment of the prone positioning. Now there are people who respond better or people who don't respond to prone positioning, but we can see in this responder here an improvement in ventilation, an improvement in perfusion after proning, and an improvement in the VQ matching during proning. Okay? So that's improved distribution of the ventilation. We can see that on CAT scan as well. So we're all familiar with these images of how consolidations seemingly disappear during prone positioning, so supine prone. But we can view an improvement in normally aerated lungs as compared to the supine positioning, and fewer areas of deaeration. Okay, so this is a lot of areas of collapsed lung here. Over-aerated lungs, so this is hyperinflation. That's disappeared as we prone the patient. So much more homogeneous distribution of the air in the lung during proning. All of these things probably mean that what we do specifically with PEEP may be less important. And there's only a couple of studies in the literature that have looked specifically at PEEP. This one here looked at the effects of low PEEP, high PEEP, and prone positioning on the P to F ratio, and you can see that moving the patient from low PEEP to high PEEP didn't give us much of an improvement in oxygenation, but proning substantially did. And that's probably due to that better VQ matching due to better distribution of ventilation during prone positioning. And you can see here also improvement in shunt fraction during proning that you don't see at high PEEP. This study compared PEEP FiO2 table to an esophageal balloon guided strategy of PEEP. And they showed essentially that the esophageal guided PEEP strategy was not different from empiric PEEP during proning, and that the regional compliance was not different. So either method worked equally well. And here, this paper showed an improvement in oxygenation during prone positioning, regardless of the PEEP strategy. They compared 3 strategies here: ARDSNet, best compliance, and transpulmonary pressure guided PEEP strategy. As we demonstrated in our paper, you can see that proning the patient improved the transpulmonary pressure in no matter what the strategy was. So here the transpulmonary pressure at end expiration was negative. Here it became positive just through the act of proning. This was transpulmonary pressure guided strategy, so it didn't change, obviously. The PEEP requirement was reduced in prone positioning in any strategy, and that the PL driving pressure, so the transpulmonary driving pressure, which is really what we want to target with our PEEP strategy, was similar no matter what the strategy was. So how do I conclude? Prone positioning functionally increases the PEEP. It decreases pleural pressure and increases transpulmonary pressure. So just the fact that you've proned the patient is going to lead to a higher level of PEEP. The changes in the chest wall elastance lead to a better distribution of ventilation during prone positioning. These effects are independent of PEEP technique. So whatever you're doing prior to proning, just keep doing that after proning. My suggested approach is keep the same level of PEEP as the patient has in the supine position when you prone them. Wean PEEP with caution. I would wean the FiO2 before I wean the PEEP, because the real danger here is when you move the patient again to the supine position. And that's probably why a lot of patients deteriorate when you put them supine again, is you've weaned the PEEP down, and as soon as you remove those effects of proning, functionally the patient begins to de-recruit in the supine position. So to me, that's the real danger. It's not proning them. There the PEEP will work pretty much whatever you do. It's when you put them in the supine position again. So thank you very much.
Thank you very much for an excellent talk. Have we got any questions from the audience? No.
I have a question to you concerning obese patients. How do you prone? What are the effects on the pleural pressure and transpulmonary pressure when they have a huge abdomen?
Yeah, excellent question. I don't know that that's been studied in terms of the effect on the pleural pressure. My guess is if the patient is very obese, it will press up and increase the pleural pressure when the patient is supine. But it really would depend a lot on the body morphology as you prone them. On the other side, if you're a very obese patient who has a lot of weight on their chest wall, by proning them, you then remove that weight. So I think it could go either way, but it's probably a good thing to study.
So, following that question, would that be a difference with pregnant patients? Do you have experience with that?
So during COVID, we did prone one pregnant patient, and we devised a special bed that allowed the belly to be sort of free in order not to hurt, the pregnancy was preserved. So we were able to have a special bed. I would think that if you're proning a pregnant patient, significantly pregnant patient, then that's going to be one-offs that you handle, as they come.
Okay, thank you very much.
Thank you all.
Thank you. So the next speaker is Professor John Marini from Regents Hospital, University of Minnesota, USA, that will address the issue of different methods of lung protective chest wall compression. The floor is yours.
Thank you very much, chairpersons. And what I'd like to try to tell you in as short a time as possible is, can we replicate the advantages we've heard about in prone positioning with chest wall compression? Now, I think we understand that increasing abdominal pressure, however we do it, will reduce the respiratory system volume. A normal individual compared with a very obese individual will have a upward compressive force related to the chest wall, a smaller lung in general, and that effect seems to not be something that we want to encourage. And yet, improvement in PaO2 relates inversely to proning's positional change in chest wall compliance. In other words, the worse the compliance becomes, the better the oxygenation becomes. This was shown by Paolo Pelosi a long time ago, and it presents a little bit of a conundrum. In ARDS, what happens? The PaO2 improves when the chest wall becomes stiffer due to proning, and proning will stiffen the chest wall. This is another Italian study from Davide Chiumello and colleagues, where they looked at the supine and prone without support features and looked at the pressures that are involved. And the pressures that are involved in the prone position are in the range of 11 centimeters of water on the belly, whereas in the supine position, it's only 0 centimeters of water. So there's about 11 centimeters of water pressure change as we move to the horizontal prone position. So the question is, if stiffening the chest wall is a good thing in ARDS, should we stiffen the chest wall and yet use the supine position? And this is an old image, and it's been tried many times. I say it's an old story because people have tried this technique before. And actually, Luciano Gattinoni, who should have been here, but unfortunately could not be here at the meeting, he once told me, we tried this once and it doesn't work, but this is an old story. If we look at abdominal weighting instead of chest wall weighting, it usually has neutral or adverse effects in some ARDS patients. I don't want to go in detail in this slide, but basically the plateau pressure does not improve whether you're at a low level of PEEP or a high level of PEEP when you place a 5 kilogram weight on the belly. This was done in Brazil by Carmen Barbas, one of the colleagues of Marcelo Amato. And in patients without COVID-19 ARDS, the weighting seemed to reduce the FRC, and compliance seemed to get a little bit worse or stay neutral of the total respiratory system, and it probably promoted collapse because the lung volume was smaller at 2 PEEP levels. But in COVID-19 ARDS, and I have taken a lot of heat for saying this at an early time, COVID-19 ARDS is not your typical ARDS. Unfamiliar mechanics occur in some late stage or severe ARDS patients. If we push on the belly, not just one cycle, but for about 10 seconds, we can elicit a response that's quite paradoxical, or what we think is paradoxical. And this was one of the first papers, paradoxically improved respiratory compliance with abdominal compression in COVID-19 patients. It doesn't make the whole system stiffer, it makes it less stiff. Even though the chest wall is getting stiffer, the whole system seems to be better. And another beautiful example of this was shown by Carteau and colleagues from France about the same time. Now, these are not small effects. In our patients, we had the plateau pressure on the left-hand panel and the respiratory system compliance on the right-hand panel. And you notice that as we do this, what we call manual belly push, we drop the plateau pressure, we improve the driving pressure, and we improve the respiratory system compliance. Not every patient will do this, but many will, especially those with late-stage and severe COVID-19. And this is an image from a summary that Luciano and I put together. Here's a patient with a plateau pressure of 40 centimeters of water before pushing. We pushed on the belly, and the plateau pressure dropped to 28, and immediately on release, it recovered to its original high level of plateau pressure. Now I ask you, what is the most common thing we do at the bedside to try to protect the lungs? And that's to look at the driving pressure and the plateau pressure. And here we're stiffening the system and making them both drop. That's pretty amazing. You know, it's a paradoxical effect. And you can reproduce that effect in many patients with either sternal pushes or with belly pushes. We tend to like the belly push. We probably change the distribution of lung volume in terms of absolute lung volume, whether we do a sternal push or an intra-abdominal push. But these are things that are still in investigation in our area. In both cases, the FRC is actually falling, but the whole system seems to be better when we measure driving pressure or tidal compliance. Now, sternal weights redistribute tidal volume and perfusion, and possibly over time will risk eventual dependent collapse of the dependent units. This is a very nice study by Rosegli and colleagues in chest in 2021 that does show that there's redistribution of tidal volume and perfusion when we sustain a weight, like putting on a heavy weight on the sternum, for example. The potential mechanisms for this paradoxical improvement by chest wall loading are basically two. We may recruit and improve ventilation perfusion matching by redistribution of regional transpulmonary pressures. We might be able to open collapsed zones preferentially and reduce dead space. But the other thing that's almost certain to be a part of it is the relief of end tidal over distension. Now, I don't mean to be too schematic here, but if we look at expiration on the bottom set of panels and inspiration as a patient gets worse, many lung units to take the capacity, diminishing to smaller number to a very severe stage, you may not find at end expiration that there's any change in hyperinflation. But if you keep the tidal volume the same, the end inspiratory strain of the baby lung units will increase with advancing injury. The point here is that it's not so much collapse anymore that we're worried about in these severe patients, it's the end tidal hyperinflation. Now that seems almost like heresy to some folks, but we're over-distending at the end of inspiration, and we're putting stretch on the lung and redistributing blood flows as well, as we look to a more severe patient with fewer and fewer lung units to take the tidal volume that we're pushing in. And if you want to schematically look at this, if you look at the blue lines, the chest wall and the normal lung, this is very familiar. Normally, we have those in opposition to one another, and under passive conditions, they balance out. If we then load the chest wall definitely stiffens and the FRC falls, but we move from a position where the blue dots are in a non-compliant range in the lung to when the chest wall is loaded, the same tidal volume will operate in a better, more compliant zone for the CARDS lung or a severe ARDS lung. So what's the implications of this paradoxical response? Well, I can do it at the bedside in any patient in a very short period of time. The belly push is a diagnostic maneuver that likely implies end-tidal hyperinflation is an important phase to consider. And it suggests that, hey, I better find a way to reduce the end inspiratory volume by using less PEEP, a lower tidal volume, or even a flatter, less upright body position. Oh my goodness, that's heresy as well. You don't want to do that. You don't want to put them flat. You want to have them upright. Well, maybe not. And if we follow lung protection guidelines and tables, they may need to be re-examined and revised if we take into account that there are these paradoxical effects in many very severely ill patients. Other therapeutic possibilities related to the belly push include an abdominal wrap of one type or another, or even a sternal compression vest. I advise you to read this paper. I only recently came across it. It's only a single case report, but it was done at a fairly early time, and my hat is off to these investigators who looked very carefully. They applied a lower abdominal compression in a semi-recumbent individual and observed a drastically decrease of his plateau pressure from 41 to 24 centimeters of water. The pulmonary compliance of 26 ml per centimeter of water, returning to the previous value as soon as it was released. They also did radiographic studies, and they found no change in ventilation distribution. This patient survived. Now, another question you might ask in the theme of proning is, does further compression also help compliance in the prone position? Oh, come on, really? Yes, it does. And we did this as well. Firas El-Mufti and one of my colleagues at the University of Minnesota did what we call a dorsal push, analogous to the belly push in the supine position. And yes, it did improve things. Now, those of us who have been classically trained know that position is a very important influence on FRC. And if we think of going to the horizontal position, it's actually a loading condition. And if we sit the patient up, it's an unloading position. But loading may be beneficial. So is it a good thing to try to go horizontal in these patients? And we think it is in certain patients. In a normal, healthy individual, it's a good thing to expand the lung, reduce the tendency for atelectasis to form, and in mild ARDS, we may recruit the patient. But in severe and late-stage ARDS, we have minimal recruitment going on, but a lot of overdistension, and that's when we get the paradoxical effect. And this is the paper that we documented showing this. This is John Seligman and one of my colleagues. We looked at the supine position in the standard 30-degree position, and then lifting the bed by another 15 degrees, and in the horizontal prone position, and lifting the whole bed without bending the legs or anything like that by 15 degrees. And what I want you to concentrate on is the driving pressures here. In the baseline condition, driving pressure is 13.9. We did a belly push and it dropped to 12.1. We then lifted the bed and took off the belly push and found that it went up to 16.7. And if we belly pushed again in that situation, we found that it fell again, the driving pressure fell down to 11.7. That was true whether it was in the supine position or in the prone position. And I don't want to go into too much detail here, but the point is it's a good diagnostic maneuver, and the possibility that changing the position of the patient, make them more horizontal, is a form of loading that we ought to quickly do in many patients, just to be sure that we're testing our original assumptions. Now, we can improve lung compliance by external compression of the chest wall, and there are many outstanding questions which I'm not going to go through in detail. How do you do it? How long? How much pressure? How do you standardize it? What's more important? And what's happening to gas exchange over time? Is it a long duration effect or is it a short duration effect? The bottom line that we found, and some others have reported it as well, is that the gas exchange actually improves, probably because you're reducing this hyperinflation, the end-tidal hyperinflation and redirection of blood flow. The ventilation improves slightly. The oxygenation does not deteriorate and may even improve. And the duration of it I'm not sure of, but I'll be glad to answer any questions that you have on that. So patients with severe ARDS may experience end inspiratory overdistension even when lung protected and auto PEEP is not detected. A simple bedside diagnostic maneuver, the sustained belly push, may reveal its presence. Dorsal compression may be an equivalent maneuver when prone. Interventions to reduce lung volume and to test for end inspiratory hyperinflation, reduce PEEP tidal volume, and assume a less upright position. And I emphasize the efficacy and safety of sustained chest compression have not been confirmed in all settings, whether you're using weights, binders, or pressurized vests. And I thank you for your attention.
Thank you very much for your excellent presentation. Any question or comment? Yes, Marcelo.
Hi, John. Driven by your publications, I tested in more or less a couple of patients doing another PEEP titration using EIT or CT with the weight and without the weight. And then there was a perfect shift of how much PEEP is required, exactly how much you increase the pleural pressure. So it was a perfect shift. So my interpretation is that when you do this push and then you have increased compliance or decreased plateau pressure, is a signal that you should decrease PEEP. I think it's very simple like this. At least it's my interpretation if I'm not missing anything. But I like it, what you said, or maybe you just should reduce tidal volume, but one of the or the other, but I think it's just a shifting. I think your graph of pressure volume curve is to the point.
Thank you, Marcelo. It is the end-tidal hyperinflation which seems to be the riskiest part, and over time these patients will expand their open lung pieces to stretch it and become more emphysematous than you would expect in somebody with ARDS. It's just a signal that you're using end-tidal pressures and stretches that are compromising gas exchange, possibly hemodynamics, and definitely lung protection if you define lung protection in a more global way of avoiding the overdistension as the prominent piece that you're trying to avoid. But there's a lot to learn and a lot more to learn in this area, I think.
Thank you very much.
Thank you.
And we would like to invite the last speaker of the session, Marcelo Amato, to give a lecture on electrical impedance tomography to assess the best posture.
Thank you very much, and thanks for staying with us till late. In the previous talks, I was talking about this kind of morphological aspect of imaging. It's a functional imaging of EIT. When you see an image like this, where ventilation is predominantly ventral, you have always this scenario on the CT. It's quite a specific signal that you have insufficient PEEP, or you had insufficient PEEP in the past. So we are starting to look at these morphological things and to have some idea what would be the best approach to patients. We are trying to have some thresholds in which you have a very high specificity, and looks like that less than 40% is a strong signal that you have insufficient PEEP, defined as a PEEP that is below a level in which transpulmonary pressure starts to be negative. And then we have tried to classify patients like this. So if they have normal dorsal ventilation, you have to have at least 25% in each quadrant. Here you have bilateral, unilateral, or one lung is completely non-ventilated. And it's interesting to see that in these three circumstances, you have a lower PO2. And this now is being validated in a very large population. And this is expected because the most perfused areas are the dorsal ones. But it's interesting to see that maybe for this condition or these three conditions, we may individualize the treatment. Some people, they have tried to understand if you have a diffuse or a focal ARDS, and they have proposed different treatments. I believe that this is absolutely true. If you have a ventilation map that is like this, it means two things. First, that you don't have focal injury, and the second thing is that your PEEP level is appropriate. And this is a signal that you are doing fine. And these guys now in Japan, they are using a lot EIT imaging the first day of ventilation, and they recognize that these patients, they have a much better prognosis in a very large series of patients. So we have tested this type of conditions in animals and in patients. So we are lateralizing the patient, trying to understand the implications for pleural pressure, because depending on the results, this could be an alternative to prone. And we have done also in
Nessa
patients.
tela da tomografia de impedância elétrica, o gráfico da parte superior representa o...
But anyway, what I would like to show is that this guy has a type of morphology in which you have just one quadrant, and then I put this quadrant up, just 30 degrees, and you can immediately see the change in the because this is the right lung, and this is the left lung. The change is big, because think about the following. This represents the change in end expiratory lung volume, okay? And the size of the oscillations is the local tidal volume. So look at the amount of increase in end expiratory lung volume. It's amazingly high. We did more experiments. We put pleural sensors here and here, and we did the 30 degrees lateralization, and we measure the plethysmogram, transpulmonary pressures, and pleural pressures. And very consistently, what happened is that we had an increase in transpulmonary pressures. Here, the experiment, in this case, it was +2, but in some animals, I observed +6. And the other side, the pleural pressure decreased, which means that I had a positive pleural pressure, and then now it's less positive. So then transpulmonary pressures increased, okay? And associated with this, end expiratory lung volume of the right side increased. So very consistent. So this increase in the plethysmogram represents increased transpulmonary pressure. We did on the CT. We put the animals inside the box and inside the CT, so very cumbersome. And then we observed that there was a big aeration, but the nice thing is that, look, this animal had a little bit of atelectasis, and this atelectasis already disappeared here and went back to supine, disappeared, so there is some hysteresis. Right, so you have an increase in lung volume. Then you can think about, so no change in PEEP. So if you do this maneuver, so it can be considered as a recruiting maneuver. And when we measure systematically, the amount of collapse decreased. I was surprised about this picture. This is the picture when the animal was in lateral position. look at how much the lung got stretched. It's much more than I was imagining. And then pay attention to this sequence, and later on I'm going to quantify how much is this stretch and how much transpulmonary pressure increase is involved in this process. So in red you have atelectasis, blue is normal lung. You see, we have here lateral position. You can easily detect that this lung was up because now it got stretched. And then you have an immediate decrease in this atelectatic tissue. Then supine again. Now I stretched this lung without changing PEEP. So you see an immediate decrease in atelectasis. And then at the end of the process, takes 15 minutes, and then the animal is much more recruited. So this is the initial situation and the final situation. Just changing the position of the patient, so the lung got bigger, much less atelectasis. Something very surprising. This was what I call, like John was talking about, paradoxical responses, but this is mind-blowing. Look at this. Okay, lung volume increases here by 50 mLs in this quadrant. Also expected, because now the whole transpulmonary pressure here is higher. Now this side of the lung, I have a decreased lung volume. Okay, I also expected this because now it's dependent on gravity. But look at this. What? This guy increased. And this happened in every single patient. And then Rolin Rodin, also in Peru, found the same things. And then took us a while to understand this. And now after doing some CT studies, additional CT studies of the belly, now we understand that the guts, they were putting their weight on top of the diaphragm, especially the opposition part of the diaphragm. And now they are putting their weight on the lateral wall of the abdominal cavity. And then, so this region of the lung also gets relieved and gets stretched, further stretched. So this is very convenient because I was afraid that I would cause atelectasis here, but this never occurred. So this maneuver is much more efficient than we were initially imagining. So something that, now I'm trying to quantify how much is this effect. So this is the right lung. The right lung got up, and this is the left lung. So when I put in lateral position, I got this increase in FRC. In EIT, you always can play these tricks. So I'm going to try to reproduce the same increase in FRC, but just turning the knob of PEEP. And this is exactly what I'm doing here now, but now you have the increase in FRC in both lungs. True, because it's PEEP. How much PEEP I needed? 8. In some patients, I needed 12 to 15, which means this lateral position means for the non-dependent lung plus 15 of PEEP. So it's a very huge recruiting maneuver. And then this is the research of Rolin Rodin. He did it in a very, let's say, manual way in South America, but it worked beautifully in the same way. So you can consider this as a recruiting maneuver if you do both sides. And here I took patients in the postoperative phase. They were full of atelectasis, and then I was measuring how much I improved the compliance in red, and the blue is the control group. And then at the end, I did a full recruiting maneuver going up to 45 of plateau pressure just as a comparison. Okay, you recruit a little bit further, but look how much of the total effect you had. For some patients, you had already the total effect of a full recruiting maneuver by just making 2 turns and 15 minutes each. So it's a very interesting maneuver in terms of compliance, in terms of driving pressure, and also in terms of end expiratory lung volume. Here, you see 1 liter of end expiratory lung volume without changing any part of any button in the ventilator. Okay, now moving a little bit further to prone positioning, because I have to discuss a little bit when I should do lateral positioning or proning position. I believe the lateral trick is a way to avoid proning, but sometimes if I have a very severe patient, I really prefer prone, and I'm going to discuss why. So again, if I have a patient like this, especially when I have dorsal hypoventilation, I immediately think about proning. But first I started to consider some other points. First, I check if I can have some response to PEEP. For instance, this patient had very little dorsal ventilation, but when I increased PEEP, this was enough. So this patient does not need prone. I can easily recruit and apply more PEEP, so this is a patient that does not need PEEP, does not need prone. But this patient, especially if this is after making some PEEP trial, this is a patient that I would like to prone directly. Maybe I can try lateral position first. If not, no response, then I go to prone. Let's talk a little bit about the response to prone. So in animal studies, we checked the difference between supine and prone, and we did a PEEP titration in those animals. I'm addressing the point raised by Danny Talmor, that you should not use first much PEEP and that PEEP doesn't matter. I think I disagree a little bit about this point. Let me try to convince you. So we did the PEEP titration. The results is that prone and supine, you have more or less the same amount of collapse at the same PEEP levels. So this was a little bit surprising because these animals in prone, so the prone is the black one. So in fact, in this series, they have a little bit more of collapse than supine. But the blood gas was much, much, much better, the double, the half of pulmonary shunt. So they had a much better blood gas with the same amount of collapse. And this was precisely because of VQ matching. So in general, these animals, they don't have a lower pleural pressure in prone, like Danny was talking about, because he measured a higher transpulmonary pressure at the same PEEP, which means that in prone, you have a lower pleural pressure. But this is not my finding. I think it varies a lot from animal to animal and from patient to patient. Look at this patient. We did a PEEP titration supine, 14. Remember, when I do PEEP titration with EIT, this corresponds to 0 transpulmonary pressure, okay? 0, 2 plus 2. We have lots of studies showing this. So then you need 14 of PEEP to have 0 transpulmonary pressure. But then when the patient was in prone, when the patient was in prone, so I needed 21. And in other patients, I see the reverse. So it's very individual. Particularly, this patient had a big belly and then got compressed, increased abdominal pressure, like Teboul was talking, and increased pleural pressures. So to overcome collapse here, I needed much more PEEP. And if I didn't do this, this would be a typical patient that in prone would deteriorate. And then you say, wow, the prone is not working, so let's put back to supine immediately. And I have seen this a lot. And typically this patient also has some hemodynamic problems. And I think now I know the explanation. So this is a typical patient in which you have higher abdominal pressures and higher pleural pressures. And vice versa. For instance, this patient at a high PEEP had much more overdistension in prone. So I think you have the whole spectrum and you should individualize. My time is over, and then I would like to just, I had some more points to make, but I would like just to go through this slide. Because after doing very systematically this approach, doing CT and doing EIT, I have a better understanding about prone, which I would like to share with you. Because I think the biggest effect of prone is something very simple to understand. It goes something like this. You have dorsal collapse. You are in supine. Then you make prone. So transpulmonary pressure is going to be higher here. And if you keep your same PEEP level, maybe you're going to have dorsal recruitment, and then slowly you're going to have a little bit of ventral collapse. We documented this. You always have a little bit of ventral collapse. And then how to avoid the deterioration when back to supine? We learned some tricks. Now we, just by, it's a rule of thumb, it's just could be +4 or +6, depending on the patient. We just increase PEEP, still in prone, then we supine the patient, and then we wait to stabilization, and then we slowly decrease back the PEEP. And in this case, we don't have deterioration when back in supine. By doing this procedure, we decrease the number of prone positions by half in our unit. So what I understood now is that prone is one of the best recruiting maneuvers that we can have. And by using this approach, we never went beyond 45 of recruiting pressures any longer. Because when I don't recruit the lung with 45, I know that by doing this, I can easily recruit this patient. Okay, so like this is a patient after a PEEP titration, after trying to do everything I could to recruit this patient in supine, but after a prone session, very quick one, this was much better later on. Thank you very much.
Have we got any questions from the audience?
Just one quick question, practical question. When you put the patient in lateral position, what is your PEEP titration after that? So do you keep the same PEEP? Or because it's similar to 15.
Yes, this is a good point. If I see that if I have, let's say, I have some improvement and then new deterioration, then I titrate back PEEP, and then I do it again with a better level, a more appropriate level of PEEP. You can do in both ways. You can upfront titrate, and then you do the lateralization, or you can do empirically. You check that there is some deterioration when supine back, and then you re-evaluate how much PEEP you need. Thank you.
Okay, thank you very much.
John is asking.
There is one question from the audience.
Yeah, thank you very much. As far as I understood, so we've heard that having patient prone, the one with severe ARDS for longer periods of time should give better results. But considering your talk, if you prone such a resistant patient, and do you see the response in prone position, and do you go up 4 to 6 centimeters of PEEP, would you still keep the patient as long prone as possible, or is it just acceptable to raise the PEEP and supine them again after 8 hours or whatever?
This is an excellent question. I had a slide precisely about this question, but I didn't have time to show. This is something that I'm enjoying very much. It's very beautiful about EIT, because you track the dorsal region right after prone, and you have to see two responses. You have to see a progressive increase in FRC and a progressive increase in dorsal compliance. And you see, when you see both, and you have a steady state, you know that you are done. But typically, I see an improvement overnight. And if I'm still in a steady improvement, I keep the patient in prone the next day. So I think we should do this more often, so do this kind of monitoring. And then for some patients, you are done even in 4 hours. And then for some patients, you really need 36 to 48 hours to get the full result.
Thank you very much.
Thank you very much. Any more? I think we need to round up the session. Thank you very much.